Question 45, which of the following best explains this patient's presentation? Okay, white cell infiltration of the thyroid, exogenous thyroid. Okay, so this is a thyroid question. Endo, specifically thyroid. 28-year-old woman presents to the clinic with 2 months of progressive restlessness, palpitations, and unintentional weight loss. Guess what time it is? Hyperthyroid time. Easy. So we know this is hyperthyroid. I'm going to skim. This is at the point where I figure out the diagnosis is the point I start skimming the rest. So fever, neck pain, blah, blah, blah. Pulse. Yep, that makes sense. Blood pressure makes sense. Brisk DTRs makes sense. Okay, so this part's important. Thyroid is not palpable. No proptosis or lid lag. So that means it's probably not Graves, but don't rule it out just because of that. A whole body iodine 123 scan is ordered and shows minimal tracer uptake in the thyroid region. So minimal uptake and no uptake elsewhere. Free T4 is high. Okay, that makes sense with our hyperthyroid presentation. Thyroglobulin is undetectable and TPO antibodies are negative. So break this one up into 2 parts. Here we've got our stem that's screaming hyperthyroid. Here we've got labs that are kind of reinforcing that with the high T4. The undetectable thyroglobulin is interesting. And then really interesting is the iodine, the scan. So that is weird. If you have a hyperthyroid patient, you would expect lots of tracer uptake, but we have minimal. So we're kind of getting mixed vibes, even within the stem itself and within the labs. Which of the following best explains this presentation? So let's go through this and see if we can eliminate things. White cell infiltration of the thyroid. This could be a couple of things. Just white cells infiltrating one of your own organs sounds like an autoimmune condition, right? Good. Not always, though. This could be a subacute or de Quervain thyroiditis, which is a post-viral invasion. So that one typically is tender, though. And I don't believe, I'm going to have to skim through here, denies neck pain. So that's probably it. I don't know if they palpated the thyroid, but it should be tender if it was de Quervain's. De Quervain, de Querpain. Yeah, they just said not palpable. They'd probably point it out if she yelped in pain. So probably not de Quervain's. Other things, this could be maybe a Hashimoto's as well for part A. That's autoimmune, that involves white cell infiltration. But Hashimoto's, it can start off as hyperthyroid, but usually that's very early and then it transitions to hypothyroid. So anytime you see Hashimoto's on an exam, it's going to be hypothyroid. So this just doesn't fit the picture for de Quervain's or Hashimoto's. What about exogenous intake of thyroid? Or in other words, if she was taking someone else's thyroid hormone medication, that would be exogenous use. So if she was taking somebody else's thyroid hormone, she wouldn't need to make her own. In fact, she would negatively feedback on her own thyroid hormone feedback loop because she's already got too much of it. So she would have a hyperthyroid picture, but no uptake of iodine because iodine is necessary to make thyroid hormone. We also have undetectable thyroglobulin, which is also necessary to make thyroid hormone. So come over here to this picture. On one side, we got blood, other side, we got the follicle, and then this is supposed to represent one of our thyroid cells. We've got iodine coming in from the blood into the follicle, and then it combines with thyroglobulin to make your MITs and your DITs. Your MITs and DITs combine to make T3 and T4, and that's your thyroid hormone. That's what then leaves and enters the blood. I have T3 in parentheses because you're producing mostly T4. So in this patient who is not uptaking, right, minimal uptake of iodine, that means the thyroid is not doing this process. It's not making thyroid hormone. And we can confirm that with undetectable amounts of thyroglobulin. So we don't have iodine and we don't have thyroglobulin. That means we are not making thyroid hormone. So how could you possibly have a hyperthyroid picture if someone's not making thyroid hormone? Well, exogenous use. That would be a perfect explanation for it because again, we are negatively feeding back on this feedback loop. We don't need to make more of it if we already have a ton of it. And so not making it represents itself as in low iodine uptake and undetectable thyroglobulin. So exogenous intake is looking pretty good right now. Let's just go through the rest for clarity. Unregulated TSH receptor activation. So unregulated TSH activation. This could be something like Graves, where you have thyroid stimulating immunoglobulins. TSI is the antibody. I always remember the name because it reminds me that it stimulates instead of antagonizes. A lot of antibodies tend to antagonize their targets, but TSIs are the opposite. They stimulate the TSH receptor. So that would definitely present with the hyperthyroid picture. But again, if you're stimulating the thyroid hormone, you're going to need iodine and thyroglobulin to make your T3 and T4. But we don't have any of that here. So that one's out. Overproduction of HCG by a tumor is really interesting. Let's come over here to this extra picture I drew out. If you thought that was a throwaway answer choice, you are in for a big surprise, as Arnold Schwarzenegger once said. Okay, so here we got HCG at the top. I've also listed TSH, FSH, and LH. And this is my representation of what those molecules look like. And what do they all share in common? Apart from terrible drawing, you'll notice that there's an alpha subunit and a beta subunit on all of these. And the alpha subunit has the same shape in every single one. The beta subunit is different in each, but the alpha subunit is the same. That means HCG actually shares some functionality with all of these hormones. And that kind of makes sense if you're thinking about a pregnant patient with lots of HCG. HCG is going to act like TSH to increase basal metabolic rate and help develop the baby. It'll also act like FSH and LH to help maintain the pregnancy. So HCG plays a lot of roles, and technically, if you had a tumor producing HCG, you very well could have hyperthyroid symptoms. But again, HCG acts like TSH in this case, so you are going to need your iodine and your thyroglobulin. So that one's out. And then autonomous thyroid hormone production, it's the same thing. It's just a tumor. It needs iodine and thyroglobulin to make thyroid hormone. So the correct answer here is B, exogenous use.